A warm good evening, everyone. Thank you so much for joining in. It's a wonderful Sunday again. We're back with the second episode of the International E-Conclave on Oral Cancer. Today, this year's theme is capacity building for oral cancer. And now we move towards a prolific panel discussion, which is moderated by Dr. Narayanan Subramaniam. Sir is currently consultant and HOD, head and neck surgical oncology at Shankara Cancer Hospital, Bangalore. As a surgeon, he has experience in all facets of head and neck oncology and skull-based surgery. He performs reconstructive microsurgery with expertise in dental implant-driven jaw reconstruction and facial nerve reanimation. Currently pursuing a PhD in oral cancer immunology from Manipal Academy. Has published over 110 peer-reviewed articles in book chapters on head and neck oncosurgery. Without wasting much time, I would like to invite Sir to take the panel discussion ahead.
Thank you very much for the introduction. It's been a fantastic session so far. So we'll move right ahead. We're a little short on time. So I would like to introduce our chairpersons for the panel discussion. So our panel discussion is on diagnosis and workup of oral lesions and radiological interpretation. Our first chairperson is Dr. Shalu, who is the principal of IDST Modinagar. She's responsible for curriculum development and she's a reviewer for various national and international journals. She has 64 publications at a national and international level and she's authored 6 books. Welcome, ma'am. Our second chairperson is Dr. Usha Agrawal, who is scientist and director at the ICMR National Institute of Pathology in Delhi. She's done her MD pathology and her PhD. She's an academician and an oncopathologist. Her areas of interest are breast and bladder cancer, biobanking, digital image analysis, and AI in pathology. So welcome, madam. Thanks for having you. Our panelists today, we've got a very diverse panel, a very skilled panel. We have Dr. Amit Janu, who is assistant professor, diagnostic and IR at TMH. We've got Dr. Prashant Vanzar, who is a consultant cancer surgeon at Sterling Hospital. We have Dr. Neha Mittal, who is a professor of pathology at TMC Mumbai. We have Dr. Aditya Joshipura, who is a consultant surgical oncology at HCG Cancer Hospital in Sola, Ahmedabad. We have Dr. Swagnik Chakrabarty, who is director of surgical oncology at Chandan Super Specialty Hospital in Lucknow. We have Dr. Manoj, who is director and clinical admin, radiation oncology at Max Super Specialty Hospital, Pattangarh, and Dr. Mittal, who is the HOD of oral and maxillofacial surgery at DJ Dental College. So welcome everybody. We're just going to jump into the panel. So I'll just share my screen. Okay, is my screen visible?
Yes, it's visible, sir.
Okay, so our panel is on diagnosis and workup of oral lesions. So the first scenario is a leukoplakia. So this is a 47-year-old female with a history of a diffuse whitish patch on the left lateral surface of the tongue. As is the definition of leukoplakia, it cannot be rubbed off. So the surface area of the lesion has been increasing over the last 3 months or so. She's not had any previous patches, biopsies, or interventions. Her only symptom is that she noticed it and maybe some vague feeling of irritation. So no pain, no bleeding, no loosening teeth, no symptoms or signs of invasive oral cancer. So this is a scenario we see very often. So we'll start off with the questions to the panel. So the first question is for Dr. Prashant Vanzar. So what history would you ask the patient that guides your management?
Am I audible?
Yes.
Yes. So, good afternoon, everyone. So, I will ask the history of the patient for an addiction, specifically the betel nut or. I will ask for the addiction for this to this lady. Any history of tobacco chewing or in any form or smoking to this, and I will examine the patient for any sharp or such another lesions or any treatment in the past. It's already have mentioned that no biopsy or an intervention previously done for this patient. So clinical examination and history will suffer for me.
Okay, perfect. Point very well taken. So you have to have a thorough history and clinical examination that helps you establish a diagnosis. So our next question is for Dr. Swagnik. So what are the management options available in this patient? So let's say we do a biopsy and it comes as mild dysplasia. So what are the management options that you would make available to this patient?
So, hello, Narayan. Am I audible?
Yep, audible.
Yeah, yeah. Hello.
Yes, we can hear you
Yeah.
well.
So, this is a diffuse leukoplakia, which is on biopsy shows mild dysplasia, which looks homogeneous to me. So, first thing, the patient has to quit the habits. Patient quits habits, and then we follow this patient up. Being a homogeneous leukoplakia, and it's extensive. So resection with clear margins may be difficult. So my call will be to observe it for 3 to 4 weeks and see how it behaves. If it stays back or it does not regress, if it regresses, we'll observe. If it stays or increases or there is some symptom that points towards malignancy, we go for a re-biopsy of the thing.
Okay, so I think that point is very well made. You have to see that you get rid of the irritants. If there's a chronic irritation or there's a habit, you get rid of it. It is a lot more challenging when there's extensive involvement. As surgeons, our hands itch a little bit. We want to excise everything that looks fishy, but it may not be a good option when you have a large diffuse area. So go with your clinical judgment. If it's homogeneous, if it can be observed, it's worth observing. So my next question is for Dr. Neha Mittal. So what is your advice to whoever is performing a biopsy of this lesion? So you have a large surface area. How do you make sure that you get a representative area?
Thank you for that question, and thank you to the organizers for making me a part of this panel. And I think my job has been made much simpler by that wonderful talk by Dr. Banerjee. And so a biopsy of a leukoplakic lesion entails, number one, that to the clinician who's performing the biopsy, I would want them to record in the form that whether type of leukoplakic lesion, is it a homogeneous lesion, is it a speckled or a nodular lesion? So type of leukoplakic lesion, to say that, the extent of the lesion, the site, of course, and whether or not there are areas which are suspicious for malignancy, and specifically pertaining to this case in which you're saying that it is a large lesion. So hence, there may be a requirement, or this may be a case for multiple biopsies or mapping biopsies, and that may be done in such a case. And in which situation it is important that the clinician clearly indicates which are the areas which are suspicious for malignancy or dysplasia. We all know that speckled and nodular type of leukoplakic lesions have much higher chances of dysplasia and harboring a malignancy compared to the homogeneous type of leukoplakic lesions. Another important point is that if possible, a part of the adjacent normal should be included in the biopsy, because comparison with normal helps a lot in identifying these early and subtle lesions which may just show mild architectural atypias and may not so much show the cytological atypias. Also, a punch biopsy is much more preferable than any type of cytological methodologies, because a punch biopsy specimen gives us, at least a punch biopsy specimen gives us the potential to do certain newer and certain immunohistochemical or certain markers, and to look at architecture much better as compared to cytological methodology.
Perfect. I think two very important points. One, that establishing the diagnosis is teamwork. So you need the clinical suspicion, you need the pathologist's expertise as well. And also that when you have a lesion like this and you're going to be following it up, there's a chance that you may end up biopsying multiple places down the line. So you may not excise it. So you may have different areas that develop dysplastic changes or malignancy. So mapping it is very important. If you can take photos, please have a way of documenting that. So the next question is for anybody who wants to take it actually on the panel. So what is the role of chemo prevention in leukoplakia? Anybody wants to volunteer to answer that?
There is no proven role of chemo prevention in leukoplakia. There has been studies that have shown there is some temporary benefit of vitamin D, but vitamin D systemic application has its own toxicities, and the lesion reverts back after after stopping the treatment. So no proven role of chemo prevention as of today in the treatment of leukoplakia.
True. I think we are lacking.
I want to add something.
Please.
Is there any role of local application of retinoic acid?
Yes, retinoic acid. Got it. So I think I agree with that completely. We had some data that was from several decades ago that showed that it may be beneficial. Chemoprevention is basically medication taken that prevents either the development of new patches or say the progression of the existing patches. But unfortunately, the effect is not durable. So once the patient stops taking it, the effect wears off, and also they have their own toxicity. So a lot of the time we prescribe patients a bunch of placebos, whether it's vitamin A or anything else. But even if we perform the patient placebos, we need to make sure that there are no side effects. So that's very, very important. Unfortunately, we don't have a very good medical management of this. So the next question is, if you have extensive leukoplakia involving the entire oral cavity, so the patient opens the mouth and all you can see is leukoplakia all over the hard palate, all over the buccal mucosa, alveola, and the tongue. How are you going to manage that? Anybody? Dr. Prashant, you want to take that?
Yes, with the permission.
Yes,
So
please.
it's being practicing in Gujarat, we oftenly used to see such type of patients with extensive leukoplakia occupying major part of the oral mucosa that can it's not amenable for surgical resection, of course. So as Dr. Neha Mittal said rightly, so there is no lesion which is absolutely homogeneous. So there are some particular part in that lesion we can of course diagnose by doing pulse biopsy or signal biopsy, and if they are malignant, then we used to treat that. Otherwise, if it is completely homogeneous, then I would like to keep under placebo treatment and do some laser sort of treatment to the aggressive looking lesions. But of course, not an aggressive surgical resection for removal of entire tumor. So it will vary patient to patient depending upon the lesion characteristic. And I will concentrate my vision to observe the abnormal looking lesions. Of course, the entire mucosa will not be, they will be having different characteristics. So I will keep the patient under observation and I will follow up the patient.
Great. Excellent point. Very well taken. You may have to combine radical interventions along with conservative ones. So if you have a focus of invasive malignancy, you resect that with margins, and you do a superficial laser kind of excision for the other areas, because you have to avoid morbidity, number one. And secondly, also, because there's no guarantee that after resecting that area, you won't have a leukoplakia popping up in another area. It's more, we think of it more of a systemic problem in the upper air digestive tract. So another question, so what is proliferative verrucous leukoplakia? So amongst all the leukoplakias, we know PVL as clinicians are the ones that we have to be worried about. Dr. Aditya, you want to take this question?
Yeah, sure. First of all, thanks for the opportunity, and thank you, Narayana sir, for this question. Yeah, so proliferative verrucous leukoplakia is an entity that is a bit distressing for us as clinicians, because it involves a broad proliferative part of verrucous leukoplakia that is extremely resistant to conventional treatment. It involves multiple confluent areas of patchy leukoplakia, out of which some of them may be proliferative and verrucous. Conventionally, it has been shown that they have a high rate of local failure, resistance to treatments, and of course a very high rate of malignant transformation later in life. So they represent a clinical and a management challenge for us.
Very good point. So we always have to keep this in the back of the mind, especially when we see elderly women with extensive lesions. A third of them can have tobacco use. Keep this entity in mind. You do not want to keep this on observation. You want to manage it radically. So the next case scenario. Yes, please.
Regarding the proliferative verrucous leukoplakia.
Please.
So it is not only a lesion which is leukoplakic lesion, so to say, oral pre-malignant lesions, or potentially pre-malignant lesions are not only a challenge for clinicians, they are also a challenge for pathologists. With if you see any kind of pathology related involving oral pre-malignant lesions, there will be a lot of heterogeneity in the diagnosis, and the heterogeneity is more towards lesions which have low amount of dysplasia. So that is why important, as I said, importance of clinically mentioning the site of biopsy, the type of lesion that we are seeing. And in that regard, proliferative leukoplakia has a special significance because, this has a very characteristic clinical appearance of this verruciform appearance of the leukoplakic whitish lesion. And on biopsy also, this is, this, as the name suggests, it is proliferative and verrucous, but may not be seen, this kind of a change may not be seen in all cases. And on histopathology, it shows a spectrum of morphological changes from early to late, in which the proliferation may be mild to severe and the dysplasia also may be from mild to severe. Then chances of malignancy are up to 50%, and a non-smoker population is the kind of population that you see these lesions are commonly. Also, this as a clinical history, these lesions may be indolent for some time and then suddenly show a very aggressive malignant transformation. So that is also known for as a clinical behavior in these cases. Very recently, as I said, there was heterogeneity in labeling these lesions. So very recently, we've had a consensus classification for identification of verrucous leukoplakia, and a group of pathologists has gotten together, and these terminologies will now be included in the new WHO book on head and neck cancers with oral lesions. So, now there is a standard pathology reporting, and I would urge all the clinicians that, encourage your pathologists to have a standardized reporting for all kinds of oral, potentially and pre-malignant lesions, mentioning of the degree of this, architectural changes, degree of cytological changes, categorizing the dysplasia at least in a binary fashion, low or high, and of course mentioning the special categories of leukoplakia, which includes proliferative verrucous leukoplakia.
Excellent point. So I think for good outcomes, it's our responsibility as clinicians to give the maximum information available to the pathologists and the radiologists and everybody else who is helping us make clinical decisions in order to get accurate information out of them. So we'll move on to the second scenario, which is tongue cancer. So this is a 29-year-old male who had an ulcerative lesion on the left lateral tongue for around 5 months. You can see tobacco-stained teeth and poor oral hygiene. He has occasional bleeding, pain, and earache. On clinical examinations, it's a 5 by 3 centimeter exophytic and fungating lesion with a partly whitish and reddish surface. There are also enlarged left level 1B and 2A lymph nodes, the largest 2 by 2 centimeter in size. So my first question is to Dr. Amit, our radiologist on the panel. So what do you keep in mind when we so we had a great discussion, of course, on imaging of tongue cancer. So what would you like to cover when you discuss MR imaging of tongue cancers? What are the salient features that you think you'd like to discuss with all of us?
Okay, thank you, Narayana. So basically, we will see the thickness of the tumor that is involving, the size of the tumor also we are taking into account, and then the local spread. So whether it is extending across the midline, going to the posterior third of the tongue, having a sub floor of the mouth involvement reaching up to the hyoid, and then spatial affinity when it is touching the neurovascular bundle, whether there is any perineural spread is there or not, or it is encasing the lingual neurovascular bundle, and then the lymphatic spread that is occurring in most of these lesions. So the one is the nodal burden and the extent of the nodal disease, whether it is encasing the vessels, whether it is an IGV or the carotid or some other structure which is potentially making it is inoperable. So these are the things actually we want to see when we are reading about a head and neck scan, especially the oral tongue.
Perfect. And the second part of that question is, what are some of the newer parameters being considered? So we've heard of ADC and other things. So what would your take-home message be as a radiologist? What do you think we should look forward to in the radiology of oral cancer?
Yeah, so definitely ADC is basically when we are talking about the cellularity of the tumor, and it is an indirect parameter when we want to assess the cellularity of the disease, and it will help in formulating whether this particular node or this particular area is going to be metastatic or not. Sometimes we are struggling whether there is an edema or there is an extent of the disease, and especially these some newer parameters like perfusion, diffusion, and other some sequences which will help you in formulating the extent of the disease as well as the metastatic burden.
Understood. So hopefully we'll see more research in these areas and they'll become more commonplace in clinical practice. So the next question is to Dr. Aditya. So what are the factors that determine resectability in a tongue cancer? So Dr. Amit summarized that up quite nicely, but for you, what are the key areas that you want to look at as a surgeon and help you in decision making?
So, firstly, I would absolutely want my radiologist and my reconstructive surgeon to be in sync with my anatomical resection before I go ahead and decide the resectability of the tumor. If I were to broadly look at the exact factor that I would look at as a surgeon in terms of removing the tumor, they would be, as I said, volume of the tongue involved, whether the lesion is crossing the midline or not, the neck nodal metastases that are there, the potential of distant metastasis in a tumor that is maybe crossing the midline or a locally advanced tongue tumor, the extent of extrinsic muscles involved or the intrinsic muscles involved, and as the paper on the compartmental resection of the tongue said, whether it is crossing compartments in terms of floor of the mouth, involvement of surrounding structures like the mandible or not. Perineural, again, I would try to pin my radiologist down as much as I can to tell me about perineural spread, because we have seen a lot of cases failing proximally in terms of involvement of the perineural bundle away from the primary tumor. That is the anatomical part of the thing. The other thing that I would consider would be the physiological part, as in if the genioglossi of both sides are involved in the floor of mouth, then that would mean that the patient might require a long-term or a short-term tracheostomy. So that is something that I would have to discuss with my patient. Even though anatomically and technically resectable, that is something that is going to give the patient a lot of morbidity in the future. Base of the tongue involvement again may cause the need to do a partial laryngectomy in order to avoid aspirations and all. So that is something that I would consider. And of course, the reconstructive need. If I have a very competent microvascular surgeon in my setup, I would be bolder in removing the volume of tongue that is necessary to achieve complete cure. If not, then that also may influence my factors. Again, all of these factors are about resectability, but they also have to be considered in terms of whether that will give a quality of life to the patient or not. So the last factor that I would say is the patient's willingness to undergo morbidity, especially in locally advanced tongue cancers.
Point very well taken. So the next question is for Dr. Manoj Dayal, a radiation oncologist. So in what oral cancers would you consider radical radiotherapy in place of surgery?
Yeah, thank you organizers for making these efforts and making this into such a good success. So radical radiation for oral cancer tumors. So it's very difficult call to take, because if it is a small tumor, say a T1 tumor, and there is no node involvement, so I will definitely offer radical radiation in these patients. Otherwise, my take for these patients will be to go for surgery followed by radiation.
Understood. So very small selected early cancers,
especially
therapy.
Yeah.
Perfect.
So the case you presented, I'll definitely ask for your surgery and followed by adjuvant radiation.
Understood. So we have to understand the advantages and disadvantages of every modality of treatment in cancer, and we have to work together to make sure that the patient gets the best possible treatment. Thank you, sir. So my next, yes, please. Sorry. So you had something to add? Sorry, did I cut you off? Your voice is breaking. Sorry. Could you repeat that last point? I think there's a network issue. So we'll go on to the next question if that's all right, and we'll come back to Dr. Manoj Dayal. So my next question is for Dr. Ankur Mittal. So in our country, we see a lot of chewing tobacco, we see a lot of pan, we see a lot of oral submucous fibrosis. So when you are seeing an oral cancer like this, but mouth opening is very poor. So if you have severe trismus, how does that make your management more challenging? So what is your approach?
Good evening, doctor. Can you hear me?
Yes, perfect.
Can you hear me?
Yes, perfect. We can hear you, sir.
Yeah. Yeah, good evening, doctor. There are lot of treatment plans which is going on in this thing. Stage 1 therapy, we used to go for a physiotherapies and exercises for the patient. Physiotherapy is like mouth stretching exercises for patient if patient can do it. Otherwise, we used to would go for mouth stretching exercises for the patients. Another thing which is most important is Christmas appliances we used to give to the patients, like scattered wooden spatulas what we give to in between the teeth, so that muscles can stretch and open it. Another thing, we can go for an Heaster's mouth gag and Ferguson's mouth gag, which we use it for mouth stretching or exercises. The next stage surgery which we use to go for is drug therapies like analgesics, anti-inflammatory drugs, and muscle relaxants, what we used to give to the patients. Newer studies we use try sometimes botulinum toxins and pentofixylin drug for muscle relaxant type drugs. The third stage surgeries we use to go for a surgeries, release surgeries like coronary and temporal muscle release, and scar revisions. If we are treating a post surgical treatment, then there is a scar and there is a difficulty in mouth opening, we used to go for scar revisions. And the last thing what we can go for is the control of infections.
Very well taken. So it's very important when oral cancer. Sorry, I think somebody is not on mute. So it's very important when we manage oral cancer. It's very important when we manage oral cancer to also think of the trismus that the patient has primarily or also will develop as a resultant of the treatment. So I think you summarized that well. If we have a patient like this with oral cancer, we may have to change our approach. We may have to do a mandibulotomy or a pull-through approach. So I think the next two questions were partially covered. So I'll go on to the next case. So scenario 3 is an unresectable oral cancer. So this is a 37-year-old male with an ulcer-proliferative lesion on the right cheek for around 9 months, which has recently become an oroantral fistula. So he has complete trismus, halitosis, pain, and bleeding. On examination, there is an extensive lesion involving the entire right side of the face with an oroantral fistula. Extensive skin involvement, including the neck skin. As you can see lower down, you can see the dilated veins on the surface of the neck and multiple hard fixed nodes in level 1 to 5. So my question to Dr. Amit is, how do you determine resectability in advanced oral cancer? And how do you differentiate between inflammation and tumor when you have extensive lesions like this?
So basically, what we see is that the disease is superiorly it is going above the mandibular notch, where we call it as an high ITF involvement. Inferiorly, where it is going into the hyoid or below that, or it is involving the hyoid. And whether there is any involvement of the mandible, whether it is paramandibular soft tissue erosions and destruction involving the floor of the mouth, and then the nodal disease, and whether it is behaving at the same, whether encasement of the vessels and any perineural spread that is going higher up into the higher ITF, or probably it going into the cavernous sinus. So these are the factors which will help affect resectability. And then whether there is any involvement in the pterygopalatine region and involvement of the pterygopalatine fossa. So these are the some factors actually where we are looking after on the imaging, and then we will help our clinician where they cannot see the disease. Second thing about the edema versus the disease, it's a tough call sometimes, but most of the time we will overestimate the disease, because most of the time when the tumors are large, the edema is going to be high, and if the lesion is matching on all the sequences that we are having, it is going to be the part of the disease. But if it is not matching, like the stir is not matching with the pre-contrast T1, then the extra part that we are seeing it on the stir or is the edema, or seeing on the post-contrast enhancement is going to be the edema. So that's how we will try to differentiate based on the conventional imaging. We have some additional markers like perfusion and diffusion weighted imaging that also increase your level of confidence whether this area is particularly an edema or a part of the disease process. So this is how we will try to stratify the patient.
Understood. So the next question is for Dr. Swagnik. So how do you palliate an unresectable oral cancer? So this is a case, obviously we cannot operate, we can't get negative margins. So how do you want to palliate this patient?
Palliation can either be radiotherapy with chemotherapy, just chemotherapy, or best supportive care. For a patient who has a local disease, which is unresectable and has a good general condition, good ECOG status, young patient, no skin fungation, palliative chemotherapy with radiotherapy is the best option for palliation. However, in cases where the performance status is poorer and radiotherapy cannot be given because either of skin grossly involvement, as in this case, or there is significant distal metastasis, palliative chemo remains a better choice. Owing to the fact that palliative chemotherapy plus radiotherapy is more toxic than palliative chemotherapy alone. Chemotherapy can either be in the injectable form or in the tablet form as oral metronomic chemotherapy, depending on the ECOG status of the patient. And the last point is best supportive care, especially for patient like this patient. Nothing can be done achieved with the chemotherapy or radiotherapy, or if the patient is elderly, poor functional outcome, no caregivers. Lot of patients we have in our country like this. Best form of palliation to palliate the pain, put in a Ryan's tube, if required, do a tracheostomy, and palliate the patient on symptoms only.
Thank you. Point well taken. So the next question is for Dr. Neha Mittal. So what are the newer tests being performed on biopsies like PDL1? So you mentioned about newer testing, punch biopsies, and how are they likely to be important for treatment?
Yeah, thank you for that question, Dr. Narayanan. And there are a few newer tests, but I would also like to take the opportunity to highlight the newer pathology-related parameters which are now being reported in oral cancers. Like it pertains probably to the previous case better, that this is the first time AJCC has accepted certain pathology-related parameters which help you better stratify, prognosticate your patients. For example, depth of invasion, the worst pattern of invasion in resected cases. And these are important parameters which have been proven to be more important than actually achieving adequate surgical margins. So yes, in cases at least in which we have achieved a surgical resection, there are pathology related parameters which must be looked at and reported and included the report. In that context, tumor budding is also coming up as a newer pathology related parameter which should be incorporated in the reports and is likely to be very soon incorporated in the standards of pathology reporting. Coming to this case, which is in which surgical resection is not possible, and what we get as a pathologist is a biopsy. And we would look for alternative and palliative methodology of treatment, or the second line, or the recurrent metastatic advanced setting of treatment. Then, as you mentioned, PDL1, yes, is worth doing and worth trying as a treatment modality. In that case, the JCO publication 2022, the result is out for the Keynote 48 trial. And it very clearly tells us that in less than 1% PDL1 positivity, it's an immunohistochemical based test, and in less than 1% PDL1 positivity, then there is no role of combining pembrolizumab with any of the modalities or pembrolizumab alone therapy. The merit is only giving these therapies in patients who have more than 1% PDL1 positivity by immunohistochemistry. So 1 to 19%, and then the other category is more than 20%. Maximum benefit, of course, in cases which have more than 20% positivity for PDL1. Certain points for PDL1, it is a companion diagnostic, PDL1 immunohistochemistry, which means that giving a particular drug requires doing the exact immunohistochemical marker which is known or which has been approved as its companion diagnostic. An example would be the companion diagnostic of pembrolizumab is the 22C3 immunohistochemical marker by DACO. Any other immunohistochemical methodology to do PDL1 is not considered an ideal methodology to report or treat with PDL1 based therapy in these patients. Similarly, we have other methodologies like SP263 by Ventana, which have their own companion diagnostic, nivolumab and all those others. So the companion diagnostic marker has to be perfect, though there are multiple studies which have indicated that the correlation between one marker to the other is quite good when we are talking about more than 1% and especially more than 10% PDL1 positivity using different types of immunohistochemical markers and methodologies. Perfect. If PDL1 is less than 1%, then higher genetic methods like tumor burden, tumor mutational burdens, and certain T cell related therapies are being are being proposed, but those are mostly in experimental setting and very in experiment and trial settings, and are not being used in the clinics as far as now.
Thank you. So I'm just going to put forth one last question, which I think I'll take. So what is end of life care in oral cancer? So in this patient who we saw, we know that we are not going to be able to treat them meaningfully. So when you know that cure is not an option, there are a few things you have to take care of. So one is to take care of oral hygiene. So you use mouthwashes, whatever dressing is possible. You need to take care of feeding. So either Ryle's tube or a peg, wherever possible. If the patient is at risk for aspiration, you may have to do a tracheostomy. You have to manage their pain, and then you have to look at any other risks that they may have in palliating appropriately. So if the patient has a risk of bleeding, you may have to give hemostatic RT, or you may think of interventional procedures. So the aim is to give them as painful and peaceful a death as possible. So even though we can't cure them, we have to think very carefully about palliative care and how to make them comfortable. So that's as much our role as operating on them or giving them radical treatment is taking care of them at the end of life. So I think we'll take some audience questions. So the first question is there any medication for puffiness of the buccal mucosa due to chewing tobacco for almost 4 years? Anybody want to take that question? So by puffiness, you mean, oral submucous fibrosis, or you just mean thickening? So usually we don't have very many medications that are effective. Usually tobacco cessation. If it's localized areas, you can do fibrotomies and things like that. People have talked about hyaluronidase injections, but not much valuable evidence on that. So I think the next question is, which biopsy is considered to be the most effective and precise? Anybody want to take that? Any of the surgeons? I guess not. So
Biopsy,
please.
hello, yeah. So this is a very important point, as Dr. Neha nicely elaborated a few points on this. It has to be a representative biopsy. That's the first point. Now, representative biopsy can be from the part of the lesion which looks most suspicious. For example, if you have a leukoplakia, find out for the most indurated part, find out the part that is bleeding to touch, or the part that is painful to touch. For a lesion which is infiltrating, not much of a mucosal disease, the best sort of biopsy is an incisional biopsy. The submucosa has to be included, and you have to go deep down to the muscle to get a positive biopsy. Second option for a proliferative or an ulcerative lesion, a punch biopsy is a very good option. However, the problem comes for a very proliferative lesion where you may lot of keratinization, and you may end up taking deep biopsies with a punch, but that may not include the basement membrane. So in those cases, the best option is to go for another knife biopsy, take a deep knife biopsy, go up to the underlying muscle so that the basement membrane is always included. Not much of a role for brush cytologies, not much of a role for FNS in oral cancer. And for small lesions, avoid an excisional biopsy, because one needs to excise the tumor without margins and it comes out as squamous carcinoma or some malignancy, then again you have to go back and revise the whole area. So best option is not to do excisional biopsy for even a small lesion. If at all it is done, then put in a suture or something like that, so that the surgeon who is operating gets an idea from where the excisional biopsy was taken.
I would like to second that. Punch at our center, Tata Memorial Hospital, punch biopsy is the most common type of oral cancer biopsy that we see, and it suffices for most of our cases, barring few of the verrucous and the hyperplastic lesions in which a deeper knife biopsy may have to be resorted to.
Aditya, you wanted to add something? Please go ahead.
If I may add to that, I think the big challenge that we face is those endophytic lesions where an actual proliferative lesion may not be visible. In that, even a punch biopsy may not be representative of the sections of the tissue that we want to assumed. So in that case, in certain cases where it is possible or accessible, even a two-cut biopsy may be the need of the hour. So so a small two-cut biopsy, because in particularly in cases of the base of tongue where the lesions are not exactly proliferative in on every time, then a two-cut biopsy is often necessary, is what we have seen in our clinical experience.
Understood. Perfect. So I think we have time for one more question. So do we need to take the normal margin in the biopsy? So I'll hand that to Dr. Neha.
Yeah, so in an obviously malignant lesion, I don't think that is required. That is, in an obviously malignant lesion, the cytological features and the architectural atypia is enough to call it a malignant lesion. But for pre-malignant lesions or for early lesions, yes, that is definitely preferable, because the lesions may be subtle, and comparison with the normal, which is of that same patient, which is present in the biopsy, is it is helpful to diagnose these lesions and classify them accurately.
Perfect. Does HPV positivity affect treatment in any way? So in oral cancer, no. In oropharyngeal cancers, we know that HPV positivity impacts the survival, big impact on survival. But in oral cancer, it's possible that patients may be HPV positive, but it probably is not involved in the pathogenesis of the tumor. So in oral cavity, no, but in oropharynx, yes, of course. So I think that's it from the panel. Thank you very much. Over to the chairpersons for their comments.
Yeah, thank you, Dr. Narayan, for the opportunity, and thank you all panelists for a very enthusiastic discussion on the various points raised. I wanted to emphasize again what Dr. Neha has already said. We have to have a uniform reporting of both the cytology as well as the histopathology all over the country, in fact globally, so that we are all on the same page when it comes to a diagnosis. Secondly, I think Dr. Narayan has emphasized that there should be a cooperation between the departments, and that should be definitely it should be our USP, so that we all cooperate together to give the patient the best diagnosis. In addition, I would like to state there are some newer molecular techniques which have come up. One of them is, I have read a paper about 1.5 lakh cases they have done with RT-PCR, which they say similar to COVID. You can now put, I think it's London-based study, Queen Mary Hospital. And if such a thing exists, we should take it up so that we have a screening modality for all our community cases. So it's easier to do screening, and we have community dentistry departments which can do such sample collection, and we do the RT-PCR back at base and then get back to the patients. And Dr. Pavan, I think, emphasized research. I think I second that, being from a research organization. I'm from ICMR, so I would always like to encourage that research be done. It's an India-specific concern, specifically related to non-smoking, that is chewing tobacco. So we have to pay the most attention to this, and I would like everybody to, all the youngsters who are listening in, to take an active role and participation. Thank you so much. Over to Dr. Narayan.
Thank you. Dr. Shalu, any comments? I think mute. We're not able to hear you. No, still not audible.
Can you hear me now?
Perfect.
Yeah, I just wanted to say that I'm pleased to be chairing this session, and it was indeed a great brainstorming and informative panel discussion where we have discussed, starting from the clinical exam, giving importance to clinical examination, then the vital dive staining, the investigations, the histopathological examination, and the treatment part. So I think it was all in one, the session, and it was an informative for all of us as a chairperson, as a faculty, and even the students might have got a lot of information in this thing. Thank you.
Thank you very much. Over to you, Shruti. Thank you very much for a great panel.
So much. I think it has been a terrific, very excellent panel discussion we have had after the technical session. So now I would like to invite Dr. Alok sir again to give the concluding remarks for the day. So over to you, Alok sir.
My compliments there. Exceptionally interesting afternoon, I must say. We finished in time enough to have our evening to ourselves. We started out with very good talks on radiology and how to look at pre-malignant lesions. But what I particularly liked was how it all culminated in the future that we can anticipate with regard to radiology, with regard to AI coming in. I'm not so sure when that future will be on us, but certainly it seems to be something that we are moving towards. The panel was exceptional, run in a very gentle manner by Narayana Subramaniam and with a very young panel, but very knowledgeable, very up to date. Loved it. If there's something that I may add to it, I must say I'm very hard put to add anything to it. But in our own practice, with regard to the first patient with leukoplakia and especially with extensive leukoplakia, we nowadays tend to use narrowband imaging to try and localize the areas which may be more sinister and which must be excised. We may use it to choose which areas to excise in patients with very extensive leukoplakia. We would, of course, use a laser in our practice to either shave off or to coagulate those areas which are leukoplakic. With regard to the tongue cancer patient, in our own practice with radiology, we are now coming around to also looking at the distance from the neurovascular bundle of the tumor. Of course, that's something that has been brought out by the TMH group very recently in a very nice publication. And if the neurovascular bundle is involved, then certainly we would look at a compartmental tongue resection. Even otherwise, we have graduated to largely doing a compartmental tongue resection for all T3s and T4s and most T2s. And the point was raised that we should be looking at free flap reconstruction, which is, of course, the best option. But in our own practice, again, the infrahyoid muscle flap is turning out to be a great option for reconstruction, both for the floor of mouth and for the tongue. Beyond that, with regard to histology, histological parameters that are coming in for tongue and oral cancer, certainly the worst pattern of invasion is now pretty well established as a significant prognostic factor. Dr. Neha Mittal did say that it might be more significant than margin assessment. I'm not so sure about that, but literature is indicating to the importance of this parameter and to its equivalence to margin assessment. We tend to nowadays use the Brandwin-Jessler staging system, which incorporates the worst pattern of invasion, which incorporates the lymphocytic response to the tumor and, of course, PNI. And we find that is very dramatically associated with both disease-free survival and overall survival. So exceptionally good panel, I must say. With regard to palliation, I would say that the one other option that we tend to use, and I'm sure everybody uses that, is to use nerve blocks for pain palliation. So if a patient has significant pain, a nerve block is often the best option in terms of pain palliation, especially if it's localized very clearly to the V3 nerve. So exceptionally good afternoon, great learning experience for me. Great to see so many delegates listening in very carefully. And of course, many congratulations to all who contributed. So thank you.
Thank you so much. I think we should have a big round of applause for all the faculty, the chairpersons, the panelists, and the moderators who had done an exceptional job in this e-conclave for day one today.